Hello and welcome to this session. At the top of the hour, we'll get started. Hello, everyone. Welcome. My name is Julie Gerges. I'm the program manager for the Early Psychosis program at Integral Care in Austin, Texas. I'm very pleased to be your host for this conference session as we move into the afternoon of day 2 of our 2020 Southwest First Episode Psychosis Conference. We have an outstanding session for you entitled Clinical Risk for Psychosis, Screening, Assessment, and Treatment. I want to thank our wonderful speaker for being here with us today, and many thanks to all of you for joining us. We truly hope that you find today's presentation engaging and helpful in your work. Next slide, please. To start off, some housekeeping items. First, we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. All attendees are in listen-only mode and cannot share video. If you have a question for the presenters, we ask that you submit it through the Q&A pod. We have staff monitoring the pod, and we will do our best to respond to as many questions as allows. If you have a comment or want to share a resource with all attendees, please use the chat box. The event is captioned. To view captions, click the arrow beside the CC box at the the closed caption box at the bottom of your screen and choose Show Subtitles. To change the size of the subtitles, click the arrow next to the closed caption box and choose Subtitle Settings, where you'll find options of making the subtitles smaller or larger. The slide deck is currently available through your Crowd Compass app. Following the conclusion of the conference, you will also post links to a recording of the sessions on our MHTTC website. If you would like a certificate of attendance or CEU certificate, a certificate reflecting your total hours of attendance at the conference will be mailed to you within the next 2 weeks. You must sign into the session through your conference registration to document your participation. Conference registrants are responsible for checking with their licensing or credentialing board to ensure acceptance of the CEUs that have been issued. Lastly, we would love for you to share your comments on social media using the hashtag SWFEP2020. Next slide, please. Disclaimer, this presentation was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are the views of our speaker and do not reflect the official position of the Department of Health and Human Services or SAMHSA. Next slide, please. Okay, so let's get started. Presenter, we have an amazing presenter for this session. Dr. Jason Schiffman is a professor of psychology and the director of clinical training at the University of Maryland, Baltimore County, where he has been since 2009. Graduating from USC in 2003, Dr. Schiffman is the co-director of the Maryland Early Intervention Program's Strive for Wellness Clinic, a research, training, and services program designed to improve the lives of young people at risk for psychosis, as well as their families. Dr. Schiffman has held numerous grants from NIMH, state departments of health, private foundations, and SAMHSA, including a SAMHSA Clinical High-Risk Psychosis CHIRP Award. He has published over 125 scientific articles related to the identification and treatment of early psychosis. Dr. Schiffman's research seeks to refine the identification of young people at risk for psychotic disorders, better understand the effects of psychosocial interventions for adolescents with psychosis, and uncover mechanisms that reduce stigma against people with serious mental health condition. Thank you, Jason, for being with us today, and I'll pass it on to you.
Thank you so much, Julie. What a fantastic introduction. I'm blushing. My only regret is that my mom isn't logged in to hear those nice remarks that you shared. So I'm grateful for that. And it's really special for me to be introduced by you because our working relationship has gone back several years now, and you've become a dear friend and a trusted colleague in this field. So I'm grateful for that. I also want to thank Jennifer and Molly, who have just been the consummate professionals and fantastic hosts in this conference, and by all accounts the conference is going fantastically thanks to you and your team. The entire UT Austin team and the South and Southwest MHTTC is really special. So I feel very privileged and fortunate to be here, and honored, quite frankly. I also want to thank friends that I see have joined as participants, and I want to introduce one special guest participant, audience member. My daughter, Chloe, is here. This is part of her CEUs for not going to school for quite some time. So that's Chloe there. She might sneak out at some point if I get boring, but she'll keep me real. In the meantime, let me go ahead and share my screen and get started. So again, my name is Jason Schiffman. I am professor and director of clinical training at the University of Maryland, Baltimore County. I do also want to mention that I will be moving to the University of California at Irvine starting July 1 of 2021. So some changes in the air there I'm really excited about. So let's see. I want to thank, in addition to folks that I've already thanked, my entire team. So all of the work that I'm representing today is a function of a team collaboration that couldn't be done by any one person. And in fact, I have, one of the most fantastic teams supporting me at every step. So this is a partial list of my folks, and their work will be highly represented throughout the presentation today. Here's what I hope to cover today. So the learning objectives include identifying signs of psychosis risk, symptoms, and distinguishing these signs from first episode psychosis. And I wanted to focus there because I know that a lot of folks who are attending this conference may have more exposure and experience with people in their first episodes of psychosis. And so I want to talk about the differentiations between first episode psychosis and risk. And some folks might not have as much psychosis experience or risk experience in general. And so defining that construct so that we're sort of all on the same page talking about the same kinds of things, I think will be useful for many. Then I want to talk about demonstrating awareness of psychosis risk screening and assessment research. And in here, I'm going to give some details about how we assess for risk, and then some practical research-oriented information about identification and screening tools, and how you can apply some of this identification efforts potentially to your own practices. Lastly, increased familiarity with psychosocial interventions for those at risk for psychosis. So I'll give you an overview of the potential of treatment for those at risk for psychosis and our approaches to that work. Before I begin, just some context. So my work is state and federally funded, and it's a partnership between different universities in my region and area, including psychology and psychiatry. I'm like the dorky one in the middle there, but those two cool people next to me are some Bob Buchanan and Gloria Reese, who have been my partners throughout this work, and for whom I'm grateful. The research that I want to be focusing on really is centered around and derived from our clinical high risk research and training and services clinic. So that Strive for Wellness, that's our logo, and that's the mental health clinic that folks attend and receive services from us. And from within that hub, we have outreach and education, we have trainings that we offer, we have program evaluation and treatment fidelity, and we have ideas around maintaining sustainability after our SAMHSA funding ends. And all of this feeds and fuels into our research. And I've selected some of our more applicable research endeavors to share with you today. Before I jump into some of the findings and research and that kind of thing, to build an overview and a rationale for this type of work, I think the most important construct that's really propelled this area forward, this area of finding folks at risk for psychosis, is this notion of the duration of untreated psychosis and the length of duration of untreated psychosis being bad for folks. So basically, if you look at this arrow and you think of it, this is like the passage of time, and different phases of illness of psychosis development are represented in the boxes within the arrow. You have premorbid phase, risk syndrome, which is where we'll be focusing on today, and in the psychosis range. If you take this line here as like the initiation or when the onset of psychosis begins, and then some time passes and effective treatment is initiated here. The duration of time between the onset of illness and effective treatment is referred to as the duration of untreated psychosis. And this is crucial in that the longer this time, the worse outcomes are in a variety of different ways. Now, in our country, on average, duration of untreated psychosis lasts 2 years. I find this to be an appalling statistic. That is to say that on average, people with psychosis are walking around without adequate care and treatment for 2 years before they're connected to ideal services. And so the work of this conference and the work that many of you all are doing is attempting to chip away at that. And certainly this notion of reducing duration of untreated psychosis has motivated looking earlier on in the risk state for the risk state of psychosis so that we can find folks prior to developing illness. And if we draw back into time and look here as the onset of the risk state, if we can find folks here and work with them prior to developing psychosis, we might be able to maybe in some cases even think about making the duration of untreated psychosis 0 days with a warm handoff from working with us to working with someone that specializes in first episode psychosis. But we also have other aspirations that are around prevention. So there is a notion that now, with some of the efforts that are being put forth across the nation and across the globe, that we might be able to prevent psychosis in some cases. We might be able to forestall psychosis in other cases. And still other cases, we may be able to mitigate the impact of psychosis, even if it does occur. And that's through a lot of our work in this risk syndrome phase, or the clinical high risk phase of illness. So I mentioned to you that longer duration of untreated psychosis is bad. So worse long-term outcomes, more intensive needs for services, more negative symptoms, more social impairment, occupational impairment, neuropsych deficits, psychological distress, and a likely increased cost and burdens to the system. Basically, anything you can imagine that's negative, DUP is associated with it. Now, there is a flip side to this, of course, and that is if we can reduce that duration of untreated psychosis, then all of these things that were negative are flipped on their head. So we have shorter duration of untreated psychosis. So finding folks early and working with them early associated with better long-term outcomes, less needs for services, less negative symptoms, less social impairment, less occupational impairment, neuropsych deficits, distress, and less costs and burdens to the system. So truly important motivation for this effort. Now, this work and this effort in general involves more than just one person. So it really takes a community or a village to help identify folks that are at risk for psychosis. And this graph or this figure shows some of the partners that we need to connect with. And many of you play different roles in your community, and it's not just mental health clinicians, but rather all the different roles that I think we all play in our communities that will contribute to us finding the folks in need, finding those folks that are at early risk for psychosis, and referring them to the appropriate mental health providers. Now, if we're drilling down into sort of mental health signs for psychosis risk, there are some things that we can look for. And I'm going to spend a lot of time talking about what might be some of the ways in which we can identify people that are at risk for psychosis. So some early warning signs include feeling like something's not quite right, or jumbled thoughts and confusion, trouble speaking clearly, unnecessary fear, declining interest in people, activities, and self-care. Maybe some comments from others. What are other people reporting about your behavior? And then a deterioration in functioning, whether it be in work or school or hygiene or other domains of life. Now, you may be saying to yourself that these are reasonable early warning signs, but for many different issues. And in fact, it is the case, and probably very well true, that if a person exhibits any or all of these, they're unlikely to be at risk for psychosis, but maybe struggling with something else. Nonetheless, these are, let's say, beginning flags for something that might be worth pursuing to potentially rule out or maybe identify someone at risk for psychosis. So these are all concerns, but they're non-specific. To dive deeper into specific concerns for psychosis risk, one of the tools that we have that helps us get into the nuances and the depth of risk is referred to as a structured interview for psychosis risk syndrome, or the SIPS. Now, this is a semi-structured interview. It takes about, 45 minutes to an hour and 15 minutes or so, depending on your comfort with the interview and how many questions that your client endorses. But it gives you a framework and a structure to identify folks that are at risk for psychosis by asking structured and standardized questions. It's really focusing in on the attenuated positive symptoms of clinical high risk. So CHR is an abbreviation that I use for clinical high risk. And attenuated positive symptoms, those are symptoms that are related to psychosis in nature, but less so in terms of severity and distress and impactfulness on your clients. The SIPS interview, it's designed to distinguish between a person that might be at low risk or no observable signs of risk for psychosis, high risk, so showing this risk stage that might sort of suggest that psychosis it might emerge soon after. And then also it helps us identify and diagnose the presence of diagnosable psychosis. So it gives us sort of three outcomes from it. Now, the SIPS, it's really focused on 5 symptom types. And these symptoms sort of map on to what you might expect to see in early psychosis or in psychosis in general. So sometimes in the SIPS verbiage and the jargon, we talk about the positive symptoms, or P1 through P5. And these include unusual thought content or delusional ideas, suspiciousness or persecutory ideas, that's P2. P3 is grandiose ideas. Now P4, perceptual abnormalities or hallucinations. And P5 is disorganized communication. And that's really like the heart and soul of the SIPs. When you're using the SIPs, it's clinician rated, so you would open it up and you'd be marking through and stuff, going through the interview. When you're rating symptoms, you see the positive symptoms there. There's also negative symptoms that the SIPs evaluates, disorganized symptoms, and then just general symptoms, which are all very useful for understanding the fuller clinical picture of your client. And then they're rated. All these symptoms are rated on a scale from 0 to 6. So 0 is absent, 5 is severe but not psychotic. So this is like the uppermost level of the risk range. And then 6 is severe and psychotic or extreme. Now, I wanted to share with you some questions from the SIPs to give you a sense not just of the instrument itself, but because the instrument is the gold standard for identifying risk for psychosis, really what I wanted to share with you is what we're talking about when we're talking about risk for psychosis or attenuated psychosis syndrome, or CHR, clinical high risk. So this is from P1, questions directly derived from the SIPs. Have you had the feeling that something odd is going on that you can't explain? Have you been confused at times, whether something you experienced is real or imaginary? Do you ever feel like your thoughts are being said out loud so that other people can hear them? Do you ever feel the radio or TV is communicating directly to you? So as you can see, these questions sort of map onto what you might expect to see from someone with psychosis. But with the SIPs, we're trying to probe at some of the lower risk range or attenuated or lesser degree of conviction and distress, as well as impairment in terms of symptomatology. So I wanted to share a vignette about unusual thought content with you, and I'll read it with you. It says, Candace reports a new and very intense interest in New Age philosophies over the past few months that has really consumed her. Since opening her mind to this way of thinking, she's noticed increasingly more signs and coincidences. She frequently sees her lucky number 8 and takes this to be a sign that she's on the right path, moving in the right direction. Oftentimes, she'll change her schedule and follow where the number 8 seems to be taking her. She also reports that over the past 6 months, when she's meditating, she'll sometimes sense a presence, which she thinks could be her spirit guide, although she wonders about this, as the presence can feel dark. Although these things have been on her mind a lot, she told you she's just not sure what's going on, and it might all be in her head. So before I talk about this and drill down into it, many folks may know someone like Candace. And so it may be the case that Candace isn't at risk for psychosis, but this is just part of her culture and her way of life. And so I'm not necessarily saying that she is at risk for psychosis, but I am saying that I'm interested in learning more. And I'll walk you through some of the ways in which the SIPs will kind of help guide that conversation forward. So here, the first thing that the SIPs wants us to do is to think about what are the experiences that the person is having. So I highlighted here interest in New Age philosophies, not necessarily psychopathology in and of itself, definitely not. Noticing coincidences and signs. For instance, seeing her lucky number 8 and taking this to be a sign that she's on the right path, okay? And then sensing a presence. So these are the experiences themselves that fall into the unusual thought content domain. Now, the next thing that the SIPs wants us to think about is the intensity, distress, and potential behavior change associated with those experiences. So it says here it's really consumed her. It's changed her schedule, and she follows where the number 8 seems to be taking her. So there's some major behavior change there. And then the last one here I'm highlighting is the presence can feel dark. So there's some potential distress that I'd like to learn more about with Candace. The SIPs also probes us to determine whether or not the experiences or the symptoms that the person is having are new. The SIPs is looking for changes, deterioration. So how have things been going? Basically, the SIPs is curious over the past year. So have things been getting worse over the past year? So looking for new things. So Candace reports that this is new. It's been happening for the past few months. So I am curious as to how she was functioning, what things were like for her prior to a few months ago. The word increasingly is in there. And then these other symptoms or experiences have been happening over the past 6 months. Now, the last thing that I want to highlight about the SIPs and the unusual thought content is this notion of doubt. So the prior sort of descriptors that I was highlighting, they were looking for symptomatology, distress, changes in behavior, what the experiences were, and the like. Now, the doubt construct here is helping us distinguish as to whether or not Candace or another person is at risk for psychosis or has crossed the threshold for psychosis. So the real key for psychosis versus psychosis risk with respect to the SIPs is whether or not doubt can be induced. So here it says, she's just not sure what's going on, and then it might all be in her head. A person with psychosis, according to the SIPs, wouldn't have that last statement be true for them. Right? They would have full conviction that things were very real. Okay, so that was P1, unusual thought content. I'm going to share some questions from suspiciousness now. This is P2. Do you ever feel that people around you are thinking about you in a negative way? Have you ever found yourself feeling mistrustful or suspicious of other people? Do you ever feel that you have to pay close attention to what's going on around you in order to feel safe? Do you ever feel like you're being singled out or watched? Okay, those are the suspicious questions. And here is another vignette. This is about a person named Philippe. It says, Philippe often feels that strangers think negatively of him, and he is generally mistrustful. He describes being vigilant in public and worries about potential harm. He's not completely convinced, but he sometimes suspects that he is being targeted. He reports feeling like he's being watched, but he is not sure who would do this or why they would single him out. Although he says he's always been a little mistrustful, Philippe noted that his feelings of being targeted have gotten worse over the past 5 months. So again, thinking about what the SIPs would guide us towards. First is the experience. So thinking negatively, generally mistrustful, suspects that he's being targeted, feeling like he's being watched. So these are the potential risk factors that are existing, the experiences for him. Drilling down about this question of intensity, distress, and behavior change. Well, he's vigilant in public, so I'd want to know if that's changed or if that's always been the case, but it must be causing him some distress, and the intensity has to be more than just nothing, and he worries about potential harm. Again, that worrying is maybe making me think about a distressful quality of this. Is this new? Well, we have conflicting information here. He says, where does he say? He's generally, he said he was generally mistrustful, but at the end, the targeted, he's saying that he's being targeted have gotten worse over the past 5 months. So some of this may have started or has been going on longstanding, but potentially getting worse more recently. And with respect to doubt, he's not completely convinced, and he's not sure who would do this or why they would single him out. So he's wrestling with it, grappling, and this is keeping him from being having a full diagnosis of psychosis. He's still in that risk phase because he's still doubting or questioning the experiences. I want to emphasize that many folks will answer questions around suspiciousness for reasons other than psychosis risk, and there's important cultural considerations that I'm going to be discussing in a little bit later on in the presentation. But I just wanted to stop there and pause and just let you know that I think deeply about issues of suspiciousness as being parts of a psychosis risk construct or responses to a sort of a unhealthy context. So we'll talk more about that later. In the meantime, let me go into perceptual abnormalities. So this is P4, distortions, illusions, hallucinations. Are your thoughts so strong sometimes that you can almost hear them? Have you ever seen things that others don't see? And do you find this distressing? Do you sometimes get distracted by distant sounds that you're not normally aware of? Here we have a vignette from Gina. Gina reported that beginning 3 months ago, she began to see wispy figures out of the corner of her eye. But when she would turn to look, nothing would be there. She also reported that occasionally she sees someone sitting in the rocking chair in her room. And at the time it's happening, the person appears very real to her. She additionally reported hearing sounds that no one else can hear, like the door slamming or muffled conversations. She'll often look to see if someone could be making the sounds, but no one is ever around when she does. She reports that these instances are distressing and do frighten her. She'll often keep the light on to help with her fears. So I think for Gina, I'm particularly concerned. I think she's got a lot going on here that makes me worried about the direction of her symptoms. The experiences I want to emphasize, the wispy figures, the corner of her eye, someone sitting in the rocking chair, that's very formed. reported hearing sounds that no one else can hear, like the door slamming or muffled conversations. So pretty intense and formed experiences there, and somewhat distressing for her. They as well. She says that they're distressing and that they frighten her. New. So many of these things she's reporting have begun 3 months ago. I'd like to probe to see what was happening before then as well. But it seems like things have gotten worse for her more recently. There's not a lot of doubt with Gina. So I want to probe more about that and ask her how convicted she is in these experiences to see if where she falls on the continuum. But relative to the other two vignettes, I think she's farther along in her, certainly in P4. Now, as a note, what the SIPS probes for is very much akin to a new label that can be found in the DSM-5. And this label is referred to as the attenuated psychosis syndrome. So in DSM-5, you can find this in other specified schizophrenia spectrum and other psychotic disorders. It has a billing code at 298.8. Now, this used to be part of what you might think of as psychosis NOS, but it lives there in this 298.8 and can be mapped on very closely to what the SIPS provides. So there's a lot of overlap there. If you're interested in more SIPS information about the SIPS, there's a SIPS website. There's some SIPS trainings. I can be reached if you're curious about more detailed information about the SIPS. All right, so that was an overview of the psychosis construct, psychosis risk construct from the eyes and the perspective and the lens of the SIPS interview. I think my intention there was to give you a sense as to the construct that I'm talking about in this presentation. Now, I want to switch gears a little bit and talk about what I think some of the needs are in this area and some of the research that my team and I have been able to conduct to, I guess, address some of those needs. So the first thing that I want to say is that I believe that there's more education that's required of mental health professionals to understand risk syndromes better. Now, in order to I guess, test that belief, we did a vignette study where we created vignettes of folks that resembled someone that was at psychosis risk. So we gave practitioners in the community a series of vignettes of folks at risk for psychosis. And we asked them several questions. And the first thing that we asked them was, what, if anything, that they would diagnose this person with, this vignette with? And what we found by and large is that folks that were mental health and general practitioners were tending to categorize people at risk for psychosis as having crossed the threshold for psychosis. So this leads us to believe that there's more room to be had to differentiate risk for psychosis from full psychosis in the mental health and the general practitioners field. So more education about risk for psychosis seems to be needed. The other thing that I wanted to highlight from this study was that when we asked the participants, the providers, what they thought would be a good intervention for folks at risk for psychosis, by and large, most folks said that antipsychotic medications would be a treatment of choice for them. Now, it's possible that some of our clients at risk for psychosis may merit antipsychotic medications, but in general, the best practice recommendations for treatment of psychosis risk is not to give antipsychotics because the side effect profile seems to be too high relative to the gains. So psychosocial treatments are the primary thought for best practices. So here we have people mistaking risk for psychosis for full psychosis, and we're having people potentially overprescribing based on their observations of what the client is struggling with. So need for help in terms of educating the providers in the community. We wanted to learn more about what types of providers would be best suited to partner with us to work towards helping folks most appropriately at risk for psychosis. And one of the things that we were noticing was that when we would give trainings, a lot of our training audience sort of seemed to have specializations in either working with kids and families or working with adults. And there seem to be very different sort of strengths of both of these groups. So what we did was we had this hypothesis that eventually was borne out, that folks that are trained to work with kids They're great with working with kids. They feel comfortable working with kids and families and schools, but they get less training and they're less comfortable working with people with psychosis or schizophrenia or risk for psychosis. On the flip side, we have people that identify as providers of adult care and that they were trained to work with adults. Now, they're very comfortable working with psychosis and they feel safe in the psychosis risk phase that I'm talking about, but they're less comfortable working with kids and schools and families. So there's a mismatch there, especially because folks at risk for psychosis are most likely to develop their early symptoms of psychosis risk in a transition-aged youth window of time. So between roughly 15 and to 23 or so. And this is a time when our systems are sort of bifurcated and split. So what you see here is that youth-focused mental health staff tend to be undertrained in schizophrenia-related disorders, and adult-focused mental health staff tend to be undertrained in working with families, youth, and in schools. And all of this is happening at a time not only when kids are at most risk for developing psychosis, but also in the context of mental health systems that tend to be bifurcated. We tend to have children's mental health systems and we have adult mental health systems. And you can just imagine, say, a 17-year-old who's in school, maybe struggling. Maybe he's not all that well connected within the school. Maybe he's not seeing a counselor, but at least there's adults that can kind of help guide him. Once he turns 18, he could check himself out of school and be a part of an entirely different mental health system, a system that would potentially let him fall through the cracks and disappoint him. So I think training is really important, and training all sorts of providers to understand the transition-aged window of time for folks as it pertains to psychosis risk couldn't be more important. Now, this is a very modest study that we did some years ago where we wanted to assess whether or not our trainings were making any difference. And in a nutshell, just summarizing the findings from this one, what we found was that for folks who attended our trainings, we were able to increase their perspective taking, their empathy. We were able to increase their behavioral expectations about what they would do when they would meet someone at risk for psychosis and how they would work with them. We reduced stigma, and we increased people's confidence in their ability to work with this population. So again, very small study, but a pilot study that allowed us to think bigger. And I want to just briefly mention a study that we're just wrapping up now, but with my partners at the University of Maryland Department of Psychiatry, as well as the School of Social Work, we created a 3-hour continuing education, psychoeducation and training program on early psychosis and screening and identification for psychosis, where we were able to reach over 1,400 social workers in the state of Maryland. And these clips here are just sort of like snapshots or screenshots of some of the training video. But by and large, what we're finding is that we're a big jump in referral volume to our specialty first episode in clinical high risk clinics has come as a result of these trainings. So we're very excited about the work and how this has been able to get the message out to potentially some really invaluable stakeholder partners and social workers. Now, I do want to mention that we will be soon, now that the study's over, mounting this continuing education on a publicly available website. So if you're interested in going through the training, it should be like a self-paced website that would be available. Send me an email. I'll be happy to connect you with that when it goes live. Now, a big emphasis of that social work training was describing the virtues and the processes of risk screening for psychosis. So I've emphasized the in-depth interviews that are a part of the SIPS interview. But for most folks, the SIPS isn't all that practical. It takes too long. There's a lot of training involved with it. But risk screening can be really valuable for folks that want to find folks that are at risk for psychosis and potentially refer them on to other people or specialty providers. So in clinical interviews like the SIPS, they have many advantages. The gold standard, they're structured. They include a lot of participant input, so you get a lot of conversation back and forth. But they take time. So, like I said, 45 minutes to an hour and 15 minutes roughly. And they require a lot of training. So there are some drawbacks. The best, I guess, the thing that's the biggest strength of them is that they're comprehensive and they give you a lot of great information, but they're not always practical. As a potential alternative, or I guess I would say a precursor to a full diagnostic interview, self-report measures provide a lot of different advantages. They're brief, they can be used in different contexts. The self-report measures for psychosis risk focus in on the positive symptoms, so they're really like zeroing in on what's most impactful for identifying risk for psychosis. They have good validity. Now, at the same time, they have potential weaknesses. In and of themselves, without a conversation, they struggle in terms of taking culture and context into account. And there's more validation that needs to be done to give us a lot of confidence in I guess, in their utility overall. Now, we're trying to do some of that research, and I'll share some of that with you as we go along here. Now, I think screening tools are a fantastic first line of for assessment, and will be a great way to trigger a referral to a specialty care clinic, either for at-risk or first episode psychosis. Now, some other advantages, as I mentioned, these screening tools, self-report, great for identifying and monitoring. They can help find people not in services. So we always have this dream of, for instance, having a very brief screening tool implemented in school systems. And I'm working with some folks in Northern California to potentially integrate some screening questions into some school settings there. They can increase the efficiency and the accuracy of SIPS evaluations or longer assessments. So most folks who screen low or don't cross the threshold on one of these screening tools, they don't, by and large, test positive on the SIPS. But if you do screen positive, then there's a pretty good chance that you're going to be also positive on the SIPS as well. And I'll talk more about that momentarily. The last thing I'll mention in terms of a benefit is that I think it's really important to emphasize that assessment in and of itself, the act of monitoring, self-monitoring or otherwise, is intervention. It's helpful. That improves people's functioning and their quality of life. So, so there's lots of good reasons for screening for psychosis. And because of those good reasons, we spent a lot of time dedicating our program of research to trying to uncover, better understand, and validate some of these tools. Now, this first study was one of our earlier studies where we were looking to see if we could find convergent and discriminant validity. And this was led by one of my graduates, Emily Klein, who's now professor up in Boston. And in this study, what Emily and the team did was administer a variety of different self-report questionnaires. Several of them were about risk for psychosis. So there was a group that were sort of all about risk for psychosis. Then there were some others that we administered that were less about psychosis risk, like, for instance, about anxiety and depression. And then there was one that we said was like very not like psychosis risk. And that was about like, I think it was about attitudes towards exercising. And what we did was we assessed how correlated each of these measures were to one another. And I'm not sure, I'm just kind of blowing this up for dramatic effect, but you'll see like on maybe the left side of your screen are the psychosis risk questionnaires, and the correlations are quite high among one another. Then as you move further to the right, you'll see the correlations diminish in strength. So things that are supposed to be highly correlated with one another are, and then as you go further and further away from the psychosis construct, the correlations get lower. So here what you see are some early evidence of convergent and discriminant validity within the screening tools themselves. This gave us some faith that we should keep pushing forward with this idea of testing these screening tools, because they seem to have some initially promising psychometric properties. But the next maybe gold standard way of assessing them would be to think about how these screening tools map on to the gold standard interview. So I talked about the SIPS earlier. A logical question is, how accurate is a screening tool with a clinician-led gold standard interview SIPS? So what's the agreement? What's the concordance between one of these self-report screening tools and a clinical interview? And here in this study, also led by Emily, what we had was a small group of folks who both took the self-report screening tools and also had a SIPS interview. And if you look down here, you'll see our accuracy from the screening tool to the SIPS interview is quite high. So between 69 and 80% of folks who screened positive on one of the screening tools were then likely to be deemed as at risk for psychosis based on the SIPS. So again, this is good criterion validity. So we're excited about that. And that made us look more deeply into the literature writ large. And Emily took lead on a review of screening tools, which is a few years old now, but I think still has some really great information if you're curious about this field. But in general, all of the screening tools that are out there had pretty good criterion validity, with about 60 to 70% accuracy overall in the literature, with most of them being relatively comparable. So there didn't seem to be like one of the screening tools that was much better than any of the others. But we did find that the ones that had a subsequent question, in addition to asking for the experience, but also asked whether the experience was distressing, those tended to have a little bit of a bump in terms of accuracy. And the prodromal questionnaire is a really great example of that, PQ, or the PQB, or the brief version. Now, the tool that we tend to use the most in our clinic is called the Prime Screen. Now, I like the Prime Screen because it was made by the authors of the SIPs and maps on really quite well to the SIPs interview. And it's also one of the briefer measures, only 12 items. So it has some strengths there. Now, we've worked with the authors, and we added a distress scale that mirrors the PQB's distress scale. So you have hopefully like the best of both worlds there, short, but also with the distress scale. And these are just some example questions, the first 4 questions on the Prime Screen. I think that I felt that there are odd or unusual things going on that I can't explain. And then the client or patient is asked to rate it between from definitely disagree to definitely agree. And then if they agree somewhat, then they're asked, when this happens, I feel frightened or concerned or it causes problems for me. Now, we've digitized this and use it on a REDCap platform within our clinic. So it's one of our innovations that helps us with recruitment for our clinic. Now, in the real world, some of these screening tools need to be evaluated. And we've piloted the Prime Screen in particular in colleges. So we have a partnership with our college counseling center. And in a study done by Liz Thompson, this was her dissertation work here. She's now a professor at Brown. We looked at the Prime Screen scores of 510 help-seeking college students that were receiving services at our counseling center. Now, of this 510, about 27% screened positive on the Prime Screen. And then we did an interview, a SIPS interview on 44 of them. And of those 44, 55% were positive for clinical high risk. So basically, there's a lot of numbers to digest, but the one that I want to emphasize here is that good overall accuracy in a college counseling center, almost 77%. So the Prime Screen's working in that context. All right, I'm switching to briefly just describe another screening tool that could be very relevant for folks. And this one's called the BASC-2. Now, the BASC-2 is much longer. It's kind of, if folks are familiar with the CBCL, it's kind of like that. But it's maybe 100, depending on what version you use, maybe between 100 and 120 questions. And it gives you a really complex or maybe a thorough evaluation of a person's strengths as well as their mental health challenges. And there's a subscale in the BASC-2 called the atypicality scale. And we've examined the atypicality scale's ability to predict SIPS diagnosis. And in fact, it works really well too. Now, I'm bringing this one up because I think it's important in that there's actually 2 things that I want to mention about this, but in that it's good to have tools that do more than just screen for psychosis risk in some contexts, and this one is a good one for that. Also, there's a good parent version for this, and what we saw here was that when you combine the self-report and the parent report, you get even better prediction than either one alone. So that additive value, I think, is really useful. So another alternative to, if you want like a more comprehensive screening tool. Another screening tool that I mentioned for some folks that I mentioned this one because some people actually already use this instrument and don't think about it as something to screen for risk for psychosis. But the KSADS, or the Schedule for Affective Disorders and Schizophrenia for School-Age Children, this is a pretty commonly used semi-structured diagnostic interview for all sorts of different diagnoses like ADHD, depression, anxiety, et cetera. Semi-structured, face-to-face interview. There are screening questions for psychosis in this, and it turns out that these questions are good predictors of SIPS diagnosis for risk for psychosis. So like questions like, Have there ever been a time when your mind played tricks on you? Or sometimes children might hear voices or see things or smell things. Has this ever happened to you? So those questions from the case ads, they work as good screening questions as well. So good accuracy here, about 78% in our sample. Now, if there's anything that's practical to my presentation today, this is what I would suggest that you like pay attention to. Like, you know, like if you think that you might be inclined to do some screening for psychosis, but don't want to get into a particular measure or anything like that, I contend that just asking these two questions could be really important for some of your clients. Now, I emphasize this because one of the things that I haven't said yet, but that's true, is that many of our clients, due to factors like stigma or fear of bringing these things up for a variety of different reasons, or just never being asked them, clients that are receiving mental health care oftentimes have symptoms related to psychosis, but no one asked them about them, not even their therapists. So 2 quick questions that you can ask. Do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt that someone was playing with your mind? Now, these 2 questions were derived from our larger battery of maybe 7 or maybe 6 questionnaires that had different items related to psychosis risk. We did a item response theory on 471 participant responses. And these 2 items come up as some of the best 2 items for identifying risk. So my recommendation in general, ask these 2 items. If a person screens high for that, think about one of the other questionnaires that you want to administer. And then if they screen high for that, think about referring to someone that can do the SIPs with them. When thinking about implementing screening tools, there's a lot of questions to think about, like who's doing the screening? Is it therapists, social workers, teachers, administrative staff, counselors, or parents? Budgetary concerns. Can you use a free one? Do you have a budget for one like the VASC? Are you screening for everyone or just people that are showing some signs? Are you giving feedback? What's your referral network? Who can you refer to? Because it's a challenge to screen folks and not know what to do with them if they screen positive. What's the general setting? Is it school? Is it pediatrician's office? Is it mental health clinic? And importantly, which tool? Now, I've gone through a list of different tools that could be applicable to a variety of different settings. And I don't really, I don't have time to go in depth about each one in particular, but I would just say as like a shorthand, we use the prime screen with distress. It's generally pretty short and it gets at distress. And then the one that I really want to emphasize is the 2-item screening. So do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt that someone was playing with your mind? Those 2 questions I think could be really useful for a lot of folks that might need help but are otherwise sort of falling through the cracks or lost in the system. All right, so validity and context. Now, thinking about screening, it's more than just asking folks questions. You really have to understand what surrounds them and their context that they live in. And it's more complicated than this simplistic symptoms of psychosis predicting to a label of clinical high risk. There's more factors at play here. And I want to share some of those thoughts around that. So there can be confounds or variables that make it seem as if someone might have psychosis risk. But in fact, this is contributing to error in this pathway from symptoms to clinical high risk label. And some of these things include factors potentially such as race or the community in which a person lives in, development, culture, or even interview biases. Now, what I contend is that if you can approach a sensitive lens towards your assessment and your evaluation and really attempt to understand the culture and the context in which your individual lives, then you can reduce some of that error and get a more clean pathway from true symptoms to a valid diagnosis and label. And I want to walk you through 4 different studies that my graduate students and recent graduates have conducted on this topic. And the first one is about race in particular. And this one was conducted by Zach Millman, who is now a postdoc at McLean Hospital in Boston. And he was looking at race. And the research question that he was probing was, are the screening tools, like the prime screen in particular, culturally invariant? In other words, does the prime screen perform equally well for participants who are Black and participants who are white? So in order to do this, what we did was look at all of our participants and their self-identified race, and evaluated whether or not the the prime screen self-report measure predicted to the gold standard SIPS interview. And what you'll see down here in this red box that I've highlighted is that there is a significant relation between high prime scores and high, which is self-report, and high clinician diagnosis on the SIPS for our white participants, but only for our white participants. For our Black participants, that link is non-significant. So there was not a statistically reliable link between self-report on the prime screen and clinician diagnosis on the SIPS for Black participants, leading us to conclude that the prime screen does not adequately assess psychosis risk for Black youth. Now, we're not exactly sure why, and we're trying to probe more deeply into this, and I'll share some thoughts about that momentarily. But at the very least, we say that the prime screen potentially lacks required context. It's not getting us enough information about what the person's experiencing and why they're circling what they're circling. Screening alone, it has the potential to over-pathologize in minority groups, at least the prime screen in our sample of Black youth. Now, all that said, and I think these cautions are very valid, I also want to mention that Black youth shouldn't be considered monolithically. So many of our Black youth would score high on the prime screen and also meet for SIPS diagnosis. And some of our white youth would screen high and not. So these are averages in an aggregate, but it's giving us a clue that there might be something going on in general for these two different races. Second study is about neighborhood and the context in which a person lives. Now, in this study, what we were thinking about was the impact of a person's neighborhood on how they answer questions on the SIPS itself. So this one's not about the prime screen or any screening tools, but rather interviews and what folks are saying in response to the questions from the SIPS. So the question here, does neighborhood crime impact responses to the SIPS? And you can get a sense as to why we were curious about this by just looking at the questions from the SIPS about suspiciousness. So have you ever found yourself feeling mistrustful or suspicious of other people? Do you ever feel that you have to pay close attention to what's going on around you in order to feel safe? Do you ever feel like you're being singled out or watched? Now, most people are going to say yes to these questions for reasons other than psychosis risk. So thinking about that really kind of generated our hypotheses around this work. And what we did here was, in collaboration with some of our community partners, we created a crime index for all of the different neighborhoods in which our participants lived in Baltimore. And what we found was, first and foremost, that neighborhood crime, the crime index, correlated highly with those questions from the SIPS. So people that lived in higher crime neighborhoods, they were more likely to say that they felt mistrustful or suspicious of other people, or that they had to pay close attention to feel safe, as you might imagine. Now, we also found some evidence to suggest that this was independent from risk of psychosis symptoms. So what we did here was we predicted the suspiciousness, P2, from the SIPS, predicted it from neighborhood crime while controlling for the other risk symptoms of psychosis. And neighborhood crime continued to predict significantly over and above the other symptoms. So neighborhood has an effect beyond just psychosis. This is important. This suggests the importance of context in individual symptom reports. So what's going on for our clients, and why are they saying yes to these questions? Now, this harkens to this notion of healthy contextual mistrust versus psychopathology. And sometimes you'll hear it referred to as healthy cultural mistrust, but I think contextual works better for me in that, like, it's no one's culture per se to be mistrustful. A culture becomes mistrustful when a dominant culture oppresses or discriminates or disparages or oppresses. So I think it's a healthy contextual mistrust and not always psychopathology. Now, that said, I want to say that there is potentially an iterative effect going on here, in that we know that factors such as neighborhood stress can lead to an interaction with a diathesis for risk for psychosis. So having risk for psychosis and being in a bad neighborhood, that could cause psychosis. But at the same time, being in a bad neighborhood could also cause someone to say that they're feeling suspicious because of the context in which they live, and not necessarily being a risk factor for psychosis. So both can live in the same space. And we're trying to tease that out even further. Interestingly, we were able to replicate this in a neighborhood in Colorado with some of our partners at Northwestern and the University of Colorado Boulder as well. So, but let me move on to the third study. And this one was pioneered by my graduate student, Pamela Rakshan Rukatar. And what Pamela was really interested in here was about age and the development and developmental periods that might be more or less sort of equipped to understand screening questions. So now we're bouncing back into the prime screen and how the prime screen lines up with the SIPS interview. And in here, what generated this hypothesis was this like clinical observation that we were seeing that younger youth seem to report more clinical high risk experiences in general. But then when you talk to them, they're like, it's like imaginary friends or, like sort of more fanciful thinking. So the question here was, do younger participants interpret screening questions as they're intended? So cutting to the chase here, if you look at the specificity of this box here, you'll see it's much lower than the other boxes. And each of these lines represents different age strata from our sample. So we have the youngest age group, which was roughly between 12 and 15, and in a middle age group, well, actually 12 to 14. Middle age group, 12 to 16, and then the higher age group was 16 and beyond. And for our younger group, our specificity was low. What that means is that our younger kids were endorsing a lot of questions on their self-report prime screen. But when we interviewed with them and talked about what those questions meant through the SIPs, they were like, no, I don't mean it that way. And it wasn't about psychosis risk per se at all. So if you're just looking at the self-report and you don't have a shared understanding, you're more likely to over-pathologize. Because younger participants tend to self-endorse more items. But when interviewed, they were diagnosed less. So maybe there's room for age-based norms that could be shared here. All right. Last study that I want to mention, also spearheaded by Pamela, who is currently our clinical intern within our Stratford Wellness Clinic and really doing a great job running the show there. So here she asked the question about factor structure and which of the questions might mean different things for different folks. With the specific question about, do items differ in meaning between respondent and clinician on the prime screen? So ultimately, she wanted to know, are some items suggestive of typical functioning? And I'm going to quickly run through here. So we did a factor analysis. We found 2 factors. And the first factor seems to make sense about questions that are related to psychosis risk. So I think I felt that there are odd or unusual things going on I can't explain. I may hear my own thoughts being said out loud. I've been concerned that I might be going crazy. Now, these are items from factor 1 from the prime screen, the self-report measure. Now, the factor 2 items, they feel a little different. I think I might be able to predict the future. I have superstitions. I might have special and natural gifts. That's the factor 2 items. Now, interestingly, what we were able to do was do some analyses that looked at the relation between these 2 factors and measures of functioning. And what you'll see here is that global and social functioning predicted higher scores, worse global and social functioning was associated with higher scores on factor 1. So the more items that you endorsed related to like feeling like I'm going crazy, the worse off you were doing globally and the worse off you're doing with your friends. But surprisingly and sort of paradoxically, from that same instrument, our factor 2 items had an inverse correlation with social functioning and didn't correlate at all with global functioning. So in other words, the higher you were with superstitions and maybe thinking you had gifts, the better your social functioning. So it's making us think that maybe some of these items aren't conveying some negative concepts or constructs, but rather they're somewhat adaptive in different climates, cultures, and contexts. So important to think about what does factor 2 really mean, and what's that all about? And maybe some items aren't pathological. Not all items or questions indicate psychopathology. Okay, so future ideas around this, well, I think it's going to be really important to understand the integration of culture and context. We need new tools. We need to adapt our existing tools, and maybe a partnership of like breaking down the system and also using what's good within the system to make that better. We always need to be mindful of things like race, neighborhood, development, culture, as well as other things like trauma and who we're asking the informant is, and making sure we understand the impact of distress and don't just look at the experiences, because an experience isn't a symptom unless it's distressing or impactful or impairing. And all of these things need to be sort of built into our risk calculators. Now, I have a lot of ideas around how we can be better informed and more sort of culturally humble in our approaches to assessment. Now, unfortunately, I don't have a lot of time to talk about these ideas, but I think maybe I'll just mention the first two, which is that these things shouldn't be done in a vacuum from researchers or even clinicians, but we need to do these in partnership within communities. And also, whether it's in assessment or research or clinical work or community meetings, allowing time and building trust is key to everything. That rapport and trust, that's where the foundation begins. I can tell you, even though I don't have time to talk about all these things are really important. And these are just like announcements that I grabbed from NIMH or SAMHSA, and that the federal government is very invested in preventing psychosis. And I contend that if we're not mindful of how we approach screening and how we approach assessment, we have the potential to perpetuate systematic discrimination and health disparities, when in fact, I think the intention is to reduce them. So that's my pitch, to be mindful of that. Now, I promised in the goals on the learning objectives to give you an overview of psychosocial interventions for those at risk for psychosis. Like, how do we work with people? Now, there's lots of different ways and different approaches, and I'm just going to share with you ours. But before I do that, I want to give you some like a motivation for some of this work. And what I'm showing here is a slide that was created by my newest graduate student, Miranda Bridgewater. And basically what it does is it takes the 12 primary studies, randomized controlled trials. I'm going to break this slide down for you now, but takes and lists them out. All right, and the height of the bars represents the likelihood of a participant that's in this research study, in one of these research studies, converting to psychosis. Now, each pair of bars represents one of a randomized controlled trial study. Now, we've not conducted all of these, or any of these really. This is a summary of the literature. So each pair of bars is a study. The height of the bar is likelihood of conversion to psychosis after a year. And the different colors represent whether the person was randomized into a control group or an experimental condition. Well, the control group varied, and so did the experimental, but the control group could be treatment as usual or could be a waitlist control. And the experimental group varied, but it was some specific treatment that was designed to help people at risk for psychosis. And all the way at the right, you'll see that when I summarize this slide, that 15% of folks that were randomized to the control condition, some waitlist control or treatment as usual, 15% of them converted to psychosis after 1 year, whereas only 8% of the folks that were randomized to an experimental condition or a treatment condition specifically designed to prevent psychosis, only 8% converted to psychosis. So you're about 50% less likely to develop psychosis if you got some sort of specialized care for risk for psychosis. Now, our specialized care for risk for psychosis takes on a modular emphasis. So modular treatments for those at risk for psychosis. And this is a paper that we published a few years back that kind of gives a good overview of how we think about care for this population. And much of the ideas that drove this came from my experience working with one of my mentors, Bruce Tropita, at the University of Hawaii when I was there as a professor early on in my career. But this idea of modularity was really helpful because we wanted to create an evidence-based approach to care, but there wasn't really an evidence base. So what do you do in this context? And making matters worse, antipsychotic medications, as I mentioned earlier in the presentation, not recommended for this stage of illness. So no antipsychotics, no evidence base. How can you create a client-driven, scientifically supported approach? Well, our answer to this was modules. And the modules can address different issues. So it's not lockstep. It integrates a variety of evidence-based approaches to care for a variety of different issues. It's flexible, but there also is fidelity. So it's flexible in that you can choose which module, but there's fidelity in that each module has its own like mini manual inside of it. And everything that we do is sort of driven and powered by shared decision-making. So the decisions around the flexibility and how to approach care are really decided by the client first with our input and our shared decisions. So where do we get our sources of knowledge? Well, there is somewhat of a burgeoning literature around CBT for risk for psychosis. And then there's already an established CBT or cognitive behavioral therapy for first episode psychosis. And we borrowed literature from there. And then general concerns of those at clinical high risk for psychosis. And I want to emphasize this point in that we find that in our clinic, it's very rare that our clients come to us and say, hey, Dr. Schiffman, I really want help with my attenuated psychosis syndrome symptoms. But rather, they say, I'm depressed, I'm nervous, I'm stressed, I'm losing my friends, I'm failing out of school, I can't keep a job, I have stress in my family, I can't get along with my mom. These are the things that people are looking for help for. And so our approach to care affords the opportunity for them to drive that and for us to have modules that are tailored to those kinds of issues that maybe have some angle around psychosis risk, but maybe not. We also have treatment that's informed by mechanisms. So the mechanism that drives our understanding of psychosis is a diathesis stress model, and that you have a stress that interacts with a pre-existing biological vulnerability. And so stress reduction can be a way to help folks at risk for psychosis as well. And of course, at every point we are trying to get input from youth and families. We have youth and family members on different advisory boards that help navigate our clinic and how we go forward with things. I'll skip this slide, but this is one of our larger flow charts. And I'm gonna like zoom in on it in a moment, but it gives you some structure, some guidance to how we approach care. And this is like the top half, so I've kind of like zoomed in, but everything starts with engagement. You know, I talked about building trust and rapport in the context of a sensitive assessment. Well, engagement is where it all begins. Without strong engagement, you don't get a valid assessment. You don't get partnership in your care. And then there's steps here along the way that guide our clinicians, you know, point by point and decision making by decision making towards an approach to care. This is the bottom half. And what I want to emphasize on this figure is that there's just one box here that says CBT for CHR. The rest, in large part, is focused on other factors like family therapy or social skills, school or occupational support, coping or relaxation, problem solving, wellness. Now, down here, you'll see we're always thinking about symptom monitoring. So if psychosis risk symptoms get higher, every week we give the prime screen to our clients to see, and then if it scores high, then we might change our trajectory a bit. But otherwise, we'll work on what the client is dictating. So let's see, I'm going to skip over this a bit, but I want to highlight that. What you'll see here is that this was like all of the modules that we used for a particular client that was struggling with some CHR symptoms. So tapped into a lot of different aspects. But that client in particular was refusing school, he had weight issues, and he was abusing drugs. And some of our different modules helped to work different aspects of some of his concerns. We've had students or clients that were runaways. One client in particular that stands out was a client that had emerging psychosis. Mom was on a wait list for a transplant, and her brother was addicted to drugs. So a lot of contextual challenges for that client. Housing issues, difficulty with school, family discord, trauma, socialization, you name it. And because the sort of the you name it part, what I want to emphasize for folks that may not have as much training or experience in clinical high risk, or been exposed to models like this, the thing is, the tools that you already have in your therapeutic toolbox, I think, are very applicable to this population. So what you can do, good principles of care include building rapport and engagement, Now, for the risk phase, best practice is to target the client's identified priorities. And there's a good chance that you'll already have skills and strategies that help work with things like social skills or occupational employment or being stressed out, for instance. So use those existing skills, ongoing monitoring and checking in on priorities. That will be important to identifying whether or not your client is receiving the adequate level of care that they need. And you can always refer out, especially if there's referral agent or there's places in your community that you could partner with. Now, we have modularized manual. This is the cover of our manual. Inside, there's some of the goodies. You'll see the flow chart there and a screenshot of one of our educational videos. That's Nikki and Pamela doing some role playing. One of the things that we emphasize on one of my grad students, Sammy J, she has been spearheading our efforts to reduce suicidality in our clients. And this is really important. And some of our partners are working on potentially a pilot program to specifically address suicidality and suicide behavior and ideation in our clients, because it's quite common. 66% of people at risk for psychosis are reporting relevant current ideation. So we have a module and plan just directly designed for that. Just some worksheets within our modules and other stuff in there. This is a couple of pictures here. The top picture is my folks from Tennessee, my friends from Tennessee who have gone through both the SIPS training with me, but also our modular approach to care training. And then the picture below it is sort of my team at our Strive for Wellness clinic. And I do like to take selfies. So this is, if folks are interested in learning more about potential CHR intervention centers in your region, this is a link that should take you to the 22 or so grantees from SAMHSA. And I just want to end now at 15 past the hour with a quote from Brandon Staglin, who is leader of One Mind, which is an advocacy and a psychoeducational group that I think folks can learn a lot from. And I encourage you to check out One Mind and the Staglin Foundation. But he says, enthusiasm and hope are what make the difference. And I couldn't agree more. I hope that that some of the message that I've been sharing can speak to the power of hope, and know that we should all think about recovery as the expectation and not the exception. And I want to thank all of my team members who contribute on day in, day out to the well-being of some of our most vulnerable brothers and sisters. And thank you so much for your time and attention. And I think we have a few minutes for some questions.
Thank you very much, Jason. We appreciate you sharing your expertise. I know we thoroughly enjoyed and benefited from the SIPS training you did in Texas. So this training was definitely the cherry on top, and glad others were able to have this valuable knowledge too. We do have several questions in the Q&A pod, and I will let April Masakanya, clinical team lead for the early onset FEP program at the Harris Center, lead us through Q&A portion today.
Thank you, Julie. Yes, we did. We got a lot of great questions. I tried to answer where I could so that we can get through these in a timely fashion. One that really stood out to me that I believe to be very, very current and relevant. Let me see if I can find it one more time. So Alana has a question. Any thoughts about administering these assessments during the pandemic when most of our clinical work is being done through telehealth?
Yes. Okay. So I'm glad you asked that question. It's challenging, right? But so let me start here. If you have a good video connection, the SIPS is thought to be valid and reliable. All right. So, but you shouldn't. The SIPS is not thought to be valid or reliable on the phone. All right. So the video, like being able to have eyes on the client, is important. I think you can also use the screening tools on video as well. Now, excuse me, where I sometimes worry is for some of many of our clients really, access to internet or, video quality internet can be a challenge. And so addressing that is important. Access to a quiet space. I mean, sometimes, we're recommending some of our clients, like, meet in the bathroom or their own bathroom, just so that they can kind of like have some privacy. But that's like, it's just sort of strange. So we're like, it's kind of like a new way of being. But the short answer to your question is the SIPS is valid on video. The screening tools I would recommend using for sure. And, we found, like with our work, I mean, this is just anecdotal, but that some folks that are at risk for psychosis are doing well in the pandemic, and some folks aren't, just like everybody else. And some people are finding it less stressful, and because they're not interacting with as many people, and that's been better for them. And other people are feeling kind of like trapped, and so I mean, I know that's not what you asked, but like a sensitivity to the new world, I think that we're all experiencing right now is really important. And we have, I don't know if there's a place for resources, but my last year's clinical intern, Joe DeLuca, as well as my entire team, wrote a paper about treatment for people at risk for psychosis during the COVID epidemic that really focuses on telehealth. So I'd be happy to refer folks to that. I think it's a really valuable resource. Thank you for that question.
Great. That was a good one. This may be a quick one. This is from Carrie. Is there a screening question regarding substances and substance abuse when you are screening with the PRIME?
That is a really good question. So the PRIME screen really just focuses in on positive symptoms of psychosis. So there's not a question about like comorbid substance use there. But, and I don't want to speak out of turn, but I think it's possible that the BASC-2 might have some questions about substance use. So if you want, like, even if it doesn't, if you're looking for something that's more comprehensive than just psychosis risk, but also has psychosis risk, think about there's actually now they're on the BASC-3, but I think those items work just as well. But think about look at the BASC. Now, I don't endorse, I mean, I don't like have stock in their company, but they do cost money for the BASC. So, if you're looking for something free, the PRIME screen or the PQB are really good options as well. But I bet there's like standalone substance use screening tools. I just don't know what they are. But it's good that you're thinking sort of in terms of like the whole person, because that type of care is really going to benefit and value your clients. So thinking about them more than just psychosis risk, but also some of the other things they might be struggling with. I love that thought. Thank you.
That was a good one. Andreas, he wants to know, he wanted to know about the congruency and using the cultural formulation interview with the SIPs. Do you have any feedback on that?
Yeah, cultural formulation interview is a really valuable tool, and you can learn more about it in the DSM, and the recent studies have suggested that when you apply the principles, you're going to there's a likelihood of changing diagnoses from people that were prior to the implementation of the tool diagnosis having psychosis. But with good cultural formulation, you can work through potential interview biases and preconceived notions that mental health professionals have, and come up with more accurate ways of doing things. Now, I don't know that I'm quite sure that there has not yet been an explicit like how to walk through with the SIPs, but the fact that the SIPs is semi-structured is a good start. And thinking about questions like what you are, Andreas, is really important. That's like the first step for all of us to be more aware of our own biases, and to think carefully about cultural considerations at every turn in assessment. Because, I mean, just as a quick note, a lot of vignette studies, we haven't conducted these, but a lot of vignette studies suggest that clinicians are more likely to ascribe a diagnosis related to psychosis or schizophrenia to a vignette that where the only difference in the vignette is that the person is Black relative to whether or not the person, relative to whether the person is white. So the same vignette, one vignette is said that the client is Black, one vignette says the client is white. More likely that the Black person is going to get diagnosed with psychosis. So there's a lot of bias that goes on that these kinds of approaches that you're attesting to are so important. So thank you for bringing that up.
Very good. I see a first initial, last name. It looks like J. Nance. When using the prime, should we only look at whether the clients answer more of the 4 and 5s, or is there a specific score to indicate clients are at risk? This has been my challenge with switching from the PQB to the prime. I like the PQB because there's a scale used to determine whether additional screening assessment is needed.
Yes. Okay. Cool. So, what was the name of this? Jay or yeah?
Jay Nance. I'm sorry,
Yeah.
I don't know.
Well, anyway, it's like super informed question there. So, like a question like that person could be running this presentation. So, I love it. So, yes. So the prime screen basically, what we recommend, or what was recommended by the authors and that we use, is whether or not they have, so it goes from 0 to 6. So if a person scores 2 5s or 1 6, then they sort of quote unquote technically cross the threshold for like, you know, us referring them to like, or we bringing them into our clinic for like a full SIPS evaluation. So 2 5s or 6. Now, what I want to emphasize though is like there's the cutoffs, which are important, but there's a whole other thing that I think is really relevant too, which is the potential to have a deep conversation with your client about what they scored. So even if it was like a 4, you just ask them, like, you know, talk to them about like, well, what does this mean? You said this. Tell me more about this. And that really can open up, you know, all sorts of different things that are like valuable for you clinically. So yeah, the cuts are 2 5s or a 6, but we go with sort of like, you know, if they say a 4 and then they like, you know, sort of expound on something that really seems, you know, at risk, then, you know, we'll bring them in and we'll do a SIPS eval with, or we won't bring them in now, but we'll do a SIPS eval with them on Zoom. And so excellent question. I hope that helps. And also, you know, sort of liberates you to use it in a way that works well for you.
Great. All right, looks like Michelle had some feedback on some vignettes. Michelle said, really interesting study on the vignettes with the professionals that diagnose psychosis based on chronic high-risk psychosis vignettes. Given the DSM does not include loss of insight as a part of the diagnosis of psychosis, would we consider a psychosis diagnosis to be wrong? We train new clinicians who have psychosis experience to assess for chronic high risk. We introduce the idea of insight as making a difference for the diagnosis of schizophrenia, even though this is not generally a part of training in her area and is not part of the DSM. Interested in your thoughts on this and whether future iterations of DSM may take attenuated versus full psychosis based on preservation of insight into account. Big question.
Oh my gosh! Wait a minute. I mean, this audience is stacked. I mean, that's
yes.
I hope that I know.
I'm trying to siphon through these too to get you the really good ones.
Yeah. So
would we consider a psychosis diagnosis to be wrong?
Yeah, I got. So here's the thing. All right. So Michelle, I think this will probably make sense to you. But like, so the DSM, like for everyone, the DSM and the SIPS, like they're not like, you know, like part of the, like, I don't know, the New Testament or something, you know. It's just like the problem is, you know, all of these are flawed. Like all of our strategies, like our categorization of human behavior is flawed. So, but what Michelle's emphasizing wisely is that not only are they flawed, but they're like flawed inconsistently with one another. So that is like a really small nuance that I think is gaining more and more attention, because, you know, as people dig deeper and more people get involved here, they're seeing these things. Yeah, and in fact, as Evelyn mentions here, they're living documents that are always improving. So, you know, will the DSM change? Maybe. Will the SIPS change? Maybe. Right now, like to the heart of the question, Michelle's point is the SIPS really looks for insight. Insight is, if insight still maintains, or is still maintained, then they're on the risk phase or side of the psychosis continuum. If insight is not maintained, then they're on the psychosis end of the continuum. Now, and I was just probably like last week, actually, a week ago today, I was having a conversation with one of the primary authors of the SIPs, and he was saying that insight is still like the thing that the SIPs kind of hangs its hat on with respect to, determining risk from full psychosis. So the SIPs is kind of, sort of adhering to that criterion, but it all could change, and I think we're all like learning and growing and getting better as we go along. So excellent question, and I have a feeling that Michelle is probably on the cutting edge of answering that question herself. So feel free to back channel me. I want to hear what she has to say. So, but excellent question.
That's great.
And true, very true. The two differ there.
Okay. Raquel is asking, thank you for the wonderful presentation, first off, and can you further describe how you would approach motivational enhancement? Oh,
yeah. So that, I'm glad you saw that. So the motivational enhancement is part of one of our sort of like spur modules in our work. And, some of our clients come to us and they're not, they're brought in by their parents or they're just not particularly motivated to work on some stuff. And that's cool. I mean, we're trying to meet them where they are. And it's challenging. The vignette that I ran out of time that I was going to share with you, he was kind of reluctant to go to treatment. And so we worked with this. So one of the modules within that is working with family members. So we were trying to motivate him to come to therapy. And he was like 16 or 17. And we were trying to get him to, he wanted to learn how to drive. And so mom would let him drive to therapy, but like that was like sort of like one of the only times that she would let him drive. So that got him to the door. And then I worked on like finding common areas of interest. So he actually was like really interested in psychology and wanted to go to college to be, a psych major and a psychologist. So like that was kind of a lucky one, but like, we looked for common areas of interest, and that's a motivational enhancement strategy. And we talked about that. And, I tell him about psychology and that actually worked quite well. And then the last thing that we did with him was, what was it? It was shared goal setting. So his goal was like, he was in a self-contained classroom and he didn't want to be there. And we worked, and some of his psychosis risk symptoms were getting in the way of him getting out of that classroom. And so we worked together to kind of come up with some shared goals. And eventually I was able to convince him that I could help him. I mean, in his journey, it was his journey and I was walking alongside him, but that I had some capacity to help. And I built trust and rapport. I went to his school, I talked to his teachers and his administrators, and that was sort of, how we did. So anyway, some like motivational interviewing and, like other, those are the specific strategies that I'm sharing there with that one. But I think you get some of the sense, but it goes back to my point about like the tools that you have in your tool belt that work for your existing clients are likely to be the ones that are going to work for those at risk for psychosis. So I think that's a really important message because you all are, even if you don't have any CHR experience or this is the only thing you've ever learned about, there's like you can do a lot of great stuff.
Thank you, Dr. Schiffman. We're definitely out of time. I tried to get through as many as I could. So hopefully there will be some training opportunities where you get to actually present and some of our attendees can attend and ask more questions and learn about the SIPs face-to-face. Thank you.
What a great Q&A session. Thank you everyone for joining us today. It has been a pleasure bringing this session to all of you. Today's presentation and slides and recording will be available on this platform at the conclusion of the conference. We also make these materials available on the Southwest MHTTC website. A reminder, we have our next session today at 3 p.m. So please join us for the presentation. Early Psychosis Intervention in Louisiana, Being Progressive to Make Progress, presented by Dr. Ashley Weiss. Next slide. Lastly, we ask that you please take a moment to complete a brief survey about today's session. Your feedback is very important to us. You will be redirected to the survey when you close the Zoom platform. It may also be available in the chat box. Thank you again for joining us, and we look forward to seeing you at other presentations throughout this great conference.
Bye, everyone. Thank you.